After insertion of CVP for a patient in ICU, his oxygen saturation dropped and started to be tachycardic.
Okay. So consider that in this case, the patient's airway is patent. That is, his airway is maintained. He can maintain his airway. Describe how you can assist and manage his breathing.
Okay, for assessment of breathing with look, listen, feel, look for the chest movement, and if there is if there is use of accessory muscle, and listen for respiratory sounds, or if there is additional sound, and if there is a stridor, and feel for the chest expansion, also percussion for if there is dullness or hyperresonant.
Okay. Anything else?
This is for assessment. For management, we'll start oxygen with high flow, or if there is a bad ventilation, we can go for intubation with anesthesia a colleague.
Okay. You will be given a chest X-ray. So describe the routine checks you would perform before assessing any radiological imaging.
Doctor, now sharing screen, I think there is no X-ray on
No,
the
I just
screen.
stopped because the stem is right now, it's not needed. That's why.
Okay.
Okay. Yeah. Will you give us, I mean, suppose you are given a chest X-ray by the examiner. Describe the routine checks that you would perform before assessing any radiological imaging.
Sorry, I didn't get you. Say it again.
What are the routine checks that you would perform before assessing any radiological imaging?
Routine what?
Routine check.
For respiratory rate or pulse oximeter?
No, any radiological imaging. What would you routinely check in any radiological imaging? I'm
Okay.
asking that.
The fragment. Yeah. You mean how to read X-ray?
No. What will you check before assessing any X-ray?
Demographic data
Mhm.
for the patient. You mean like?
Continue. I'll be telling you later on.
Okay. For the patient age, name, and the site and the name of the hospital. For a reading of the X-ray with a air with fields, and for cardiac, if there is increase in cardiac ratio, or a knock
Someone's
bonnet.
mic is on, and that is disturbing. Okay, Dr. Isra, continue.
Okay. Continue. Okay, for the cardiac ratio or the diaphragmatic shape, if there is and costophrenic angles, if there is air under the diaphragm, and we will check reps if there is fracture, subcutaneous emphysema, or if there is
Okay.
shifting time.
Okay. So I mentioned that whether the routine checks you would perform before assessing. Okay. So before assessing, what you see the name, date of the patient, date of birth of the patient, hospital number, and date and time of imaging. That's it. Because the rest of the things that you are telling, these are like assessment. Because first you will see whether this belongs to this patient, the respective patient, or not. Then you will see whether the patient has any emphysema or any cardiac shadow or any cardiophrenic angle or any cardiac ratio improper. So
And
you just tell the demographic data that you will see, that the name of the patient, date of birth, hospital ID, and or the hospital name, and the date and time of imaging. These are the things that you need to check. Okay. Okay. So can you please tell me the name of the system that you will use in assessing the clinical aspects of the film?
name of a
system that you will use to assess the clinical aspects of any film, radiological film.
ABC, you mean?
Well, earlier it used to be ABC. Now it's since that patient has trauma, and in this case, it's better you can say that is the ATLS system. Okay,
ATL. Oh, okay.
ATLS system.
Life trauma support.
Yes,
Yes.
yes. Can you please tell me the types of pneumothorax?
Yeah, it may be simple or complex, maybe tension or a simple or tension, maybe it, congenital or acquired, and maybe open or closed.
Please don't tell congenital or acquired. It's primary or secondary. Okay.
Okay.
So
Primary.
can you please tell me what are the techniques that you need to use while inserting a jugular venous line?
Jugular venous A?
Yes.
We have to do it under ultrasound guided. Also, after insertion, we can recheck with the radiology to see the tip of the catheter in the superior vena cava or near the right atrium.
I asked about the technique. You were saying that what you will do before and what you will do after. Tell me the
There
whole
is,
technique.
okay, there is three techniques: anterior and central and posterior. Anterior insertion in the Uh, insert the catheter at the anterior border of sternocleidomastoid, just lateral to the carotid pulsation. Then insertion of the catheter toward the patient ipsilateral nipple at the angle of 30 to 45. Central, we can insert the catheter between the two heads of sternocleidomastoid above the middle third of the clavicle, also to the ipsilateral nipple at the angle of 30, and a posterior technique to insert the catheter midway between the mastoid process and the clavicle on the posterior border of the sternocleidomastoid, but the direction of the needle will be to the suprasternal notch in the angle of 45 degree. You can retract the sternocleidomastoid to make the external jugular vein away of the pathway.
Okay, I think you not saying it wrong, but I think you can shorten it a bit, because if you spend this much time in one question, you will have more other questions you need to answer. Okay. Okay,
You
let me
mean
go to
say anterior, central, posterior? Just
You don't have to say this. Just say that you will find a midway between the sternoclavicular notch and the mastoid process, and you will feel the carotid pulsation, and you will insert a needle 1 centimeter lateral to that, directing the needle towards the ipsilateral nipple. And then you will insert the needle at an angle of 45 degree, just it. And after that, you will be doing an ultrasound so that you can check whether the CV line is in place or not. Okay?
okay.
Okay. So what position should a patient be kept when a central line is being removed, and why?
In Trendelenburg position to avoid air embolism
What position?
and reverse it Trendelenburg.
Supine position to avoid air embolism. Don't tell reverse Trendelenburg. Just tell
What?
supine. Supine.
Okay, I read it. This is to make the head at the lower level to avoid air embolism.
It's better if you tell supine.
Okay.
Okay. Other than pneumothorax and air embolism, can you please tell me what are some of the immediate complications of central line insertion?
Injury to surrounding structure may rupture of vessels or pneumothorax, injury to pleura, pneumothorax, arrhythmia. Um,
I think you told
that
all. You don't have to do anything else.
sorry.
I think you told all the three things that are needed. You don't have to tell anything else. Because
Okay.
when I was practicing, I was told that these are the things that remain in the checklist. So sometimes if you tell extra, it just wastes your time. And so better not to tell those things, because
There is a
like,
checklist.
yes.
Which answer is written? Which answer?
Okay, as far as I know, that you told that there is injury to the surrounding structures, air embolism, and arrhythmia. I think these three will be all right. If you
Hmm.
tell anything, it might be extra, but sometimes people who are like fast speaker like me, I can finish within. I can finish easily because I speak fast. But sometimes
Hmm.
people who speak slowly, they take time for finishing, because at the end things start to get hazy, like in your brain it gets hazy. So try to keep the answers as short, like just to the point, just as you learn. Don't try to
Um,
overthink much.
I'm
Only
afraid that the
hmm,
examiner may will not ask what else. Then he will think that I don't know more. Then we will not give the mark. But I don't know. He
if
is.
you can tell what else, if he asks what else, and if you don't remember, just tell that I would like to answer it later.
I mean, if he wants to add, he will ask.
Yes, he will.
Hmm.
But in my exam, I don't think any examiner did that, because the diet I gave exam, the pass rate was only 31%. So, and I asked everyone, no one else asked like what else was it. I think only in 2 stations I got, I think that they asked what else, only if the examiner did good. They used to ask it only if they think that the examiner is doing it good, and they can help him getting a better mark.
Hmm.
So I think that depends on the assessment of the examiner. If he thinks that you are doing good and you need some help, because I remember in my critical care station, I was in the aortic aneurysm. I could answer all the questions. Just like in the final part, he was asking what medication you can use to stop bleeding. I was not remembering. He's all like, okay, take some time, and I answered some of them. He then asked what else, till I give the right answer. So it depends that when the examiner is thinking that you are giving good answer, he will help you.
Hmm.
And it usually happens in the Edinburgh College. I don't think in England or other colleges they do that, as far as I know. Okay, so let me ask the next questions. What are the commonest organisms that are associated with the central venous line infection?
Staph aureus, Thrips biogene.
Another one is coagulase negative staph.
Negative what?
Coagulase negative staph, Staphylococcus. Coagulase negative Staphylococcus. You know the names, right? Staphylococcus epidermidis and Staphylococcus saprophyticus. These are coagulase negative, right?
Staph aureus, staph epidermidis, staph
Yes. And
subcutaneous.
yes. And coagulase negative Staphylococcus.
Okay.
Okay. Can you please tell me what are the factors that predispose to central line infection?
Risk factor maybe due to the patient immune compromised or less hygiene of the dressing dressing that is soaked without uh, change or
Okay. So I think it's an important question, because this station is very important. Let me discuss. And I'm discussing it with you guys because I think you guys can complete it within time, given the pace that you are going. You guys have good pace. You guys are doing great. But okay, but sometimes the things that needs to be fine-tuned. So you are telling it right. I'm not saying that you are telling it wrong, but start with the point that the side and the highest choice of the side is femoral, because if femoral line is given, it is near the groin area, it might get infected with due to stool or urine. Okay, so firstly we'll tell that if the site is the femoral side, poor handling technique, if the port is not cleaned before and after use, if the dressing is not changed when it is soiled, if we are not keeping a dedicated lumen for total parenteral nutrition administration, if the central line is kept for a very long time, and lastly, if the patient is immunocompromised, if he's getting chemotherapy or he's in chronic illness. Okay, Dr. Isra?
Okay.
Okay. Can you please tell me the safety triangle for chest tube insertion?
Yeah, the anterior border is the lateral border of pectoralis major, and posterior border is the anterior border of latissimus dorsi, and a line drawn from the navel backward.
Good. So another question, I think for left for this part. Can you please tell me what are the indications of central line insertion?
Maybe for insertion of some drugs like potassium and TBN, also for dialysis, also for cardiac pacing, or for insertion of if there is difficulty for peripheral line insertion.
Okay. Yes, you told all the points. Very good. So, Dr. Isra, you did great, and I think you have only some days left for your exam, right?
Yes, 4 days, inshallah.
Thank you so much. You did
What's your
great.
advice? What's your advice for this remaining 4 days?
I don't have any bad, but because I remember I was almost, perplexed during the last days, and I used to cry a lot. And it's normal that you cry a lot because you are afraid, because we all have invested we all invest a lot of money in this exam. So I think for the last few days my advice would be just keep revising all the things. Don't avoid any stations because anything might come. So please don't think like these are the suggestions I think I need to see this. Just give a look at whatever stations you can, because sometimes suggestions don't fall in common, and if you find in the exam that your suggestion is not falling in common, you would be very perplexed. Okay, and right now I think a lot of people and have this like a lot of pilot stations are being given. Try to collect those pilot stations if possible. I think in the last exam of the Edinburgh diet that was taken in I think that was taken in Edinburgh, the last one in October. I think some of the pilot stations came, some new stations came. So try to see, you don't have to practice all this, but just try to take a look, because if it might come, if Allah forbids, but the station comes, at least you can answer one or two things. Okay.
Mm-hmm.
And I don't have any other advice. Try to do whatever you can and have a good night's sleep. I remember having a tranquilizer before the exam so that I can have a good night's sleep, because sleep is very important.
Mm-hmm.
Sleep is very, very important.
Mm-hmm. Yeah, okay, thank you.
Okay, so I would like to check another people who would like to do the next part. I think I don't have much questions left.
Yes, I'm able to.
Okay. So can you please tell me what are the things that you can see here?
I'm able to see chest X-ray along with the. Should I tell you the only abnormal findings?
Yes, just whenever you ask us what you will see here, you can tell the abnormal findings, because you won't have time to see say all the other things.
Okay. It is right-sided pneumothorax. Okay, it is right-sided pneumothorax.
Okay, and what else?
And that's it. Uh, and it, yeah, there is a tracheal shift as well. Mediastinal shift
Okay,
to the left.
okay. What else?
Sorry, I couldn't understand. Please.
In case of pneumothorax, it's very important to tell that it has a lung collapse. You can see, right? You can see that there is lung
Yes.
collapse. Always mention that there is lung collapse. Okay.
Okay.
Can you please tell me how will you manage this patient?
In emergency, if the patient do present with the tension pneumothorax, though, first of all, I'll go for needle decompression. If it's adult, then I'll do needle decompression via the fifth intercostal space mid-axillary line on emergent urgent basis, and then I'll go for intubation, chest intubation.
Okay, but okay. Okay. You can start with it saying that you will follow the advanced trauma life support protocol and then explain the rest. Because in these types of stations, as I have said earlier also, that professionalism is a very important thing. And whatever the type of trauma, start with that you will follow the advanced trauma life support protocol. And if it's a critical care case, try to say with care of critically ill surgical patient protocol. I know a lot of you we are always practicing it pre-sport years. Just whenever you practice it by yourself, tell the full form. The care of critically ill surgical patient protocol, advanced trauma life support protocol. Okay. Can you please
Okay.
tell me what are the classes of hemorrhage?
Classes of hemorrhage. Is it about shock? Is it about arterial
Just tell me
venous?
the classes of hemorrhage.
But I'm unable to get it. Did you ask about the hemorrhage classification?
Yes, I'm asking the classes of hemorrhage. Classes of simple question. Okay, let me explain. Just tell class 1, 2, 3, and 4. The percent and along with the percentage of blood loss. In case of class 1, it will be less than
Okay, okay,
16%.
okay. Okay. Type 1, 2, 3, 4. You were mentioning. Now I get it. Type 1, it
Class
is
1, 2, 3, 4. Class 1, 2, 3, 4. Just till like
class 1,
as
2,
I
3, 4.
classes, you can say that whenever the examiner will be, you can tell the class 1, 2, 3, 4, and just mention that amount of blood loss in percentage. That would be easier for you. Okay.
Okay.
So consider that the
So,
patient uh, you 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 already
yeah.
answered. I don't have any problem with that. But just I was like making you understand because sometimes the questions are a bit twisted because we are reading a lot of things and we have to remember a lot of things for that exam. You are memorizing the skill questionnaire, but you have to keep in mind the examinations, counseling, the history, the phone call, and a lot of things. Okay, so sometimes the questions are twisted just to
Yeah.
check you whether you do well in pressure or not. Okay, so
Okay.
that's why sometimes it will be twisted like that. So consider that the patient's
Okay.
airway and breathing has been managed. Okay, so how will you
Okay.
manage the circulation of the patient?
Following the ATLS protocol, I'll be going to maintain an IV line first of all. Then I'll assess, meanwhile, the blood loss, and then I'll go for the fluid bolus as far as adult and children protocol is. That is 20 milligram per kg per into a bolus form. And meanwhile, I'll do blood tests for blood grouping, and I'll be discussing the case with my senior consultant though.
How will you manage the circulation? Just tell me the circulation portion. You don't have to, consult the senior. Just tell me the things that you will do while managing the circulation for the patient.
First of all, I'll assess from where the blood loss is. If it is obvious injury, I'll just pack it, and afterwards, meanwhile, following the ABC protocol and ATLS protocol, I'll check for the signs of tachycardia and tachypnea along with the blood pressures and GCS as well, and then I'll go for our I'll maintain IV line as well. And if it is any high energy trauma, I'll be following fluid replacement as well as, depending on the blood pressures and pulse rate, may I go for the fluid as well as the blood RBC to be given if needed. So summarizing it up, I'll go for the two large bore
Okay.
IV line.
You are not
I'll go for
wrong.
grouping.
Okay. But don't you have tell, then you are summarizing. Just avoid that. Just tell the summary, okay, that you would be stopping any obvious source of bleeding. Then you'll again access by 2 white bore, 1 convulsions and the same things. But don't whenever you are telling a good large question, then you are summarizing. That will just waste your time. So in these things, that the things that you have missed include, you have to take blood for doing some tests that includes checking full blood count, glucose, urea, electrolytes, ABG, and you have to cross match for 4 units of whole blood and commence IV resuscitation of 1 to 1.5 liter of crystal mass. You need to consider blood transfusion if there is no response to fluids and insert urinary catheter so that you can monitor the patient. Okay, that would be all. I don't think you need anything else. Okay. So when you are managing this patient's circulation, what are the things that you will monitor to see the response of the patient?
I'll maintain the systolic blood pressure above 90, and urine output which should be more than 0.5 milliliter per kg per hour, and patient's GCS as well as the peripheries should be normalized.
Okay, you are telling your desk time that you will see these. Just tell the parameters that you will monitor. Name of the parameters.
As far as the monitoring is, I'll monitor ECG, blood pressure, saturation, and urine output.
Heart rate, blood pressure, capillary refill time, and mental status also. So remember 5 things: heart rate, blood pressure, urine output, capillary refill time, and urine out. Sorry, mental status. Okay.
Okay.
Okay. So sometimes in these types of cases that I'm saying that this the patient also comes with liver tear and it might be given a CT for that. I'm sorry, I couldn't find any CT for liver tear, otherwise I could have shown you. So can you please tell me what are the grades of liver tear? Do you have any idea of that?
What are the grades of
liver tear?
Yeah, there are 5 grades to it. One is that contains superficial laceration, and it contains a blood loss of less than 10% surface area. It does cover. In type 2, it is laceration of up to 3 centimeter, and in type 3, it is laceration more than 3 to 7 centimeter. It is up to 3 to 7 centimeter, and in 4 it is more than 7 centimeter, and it may involve the parenchymal disruption, and in 5 it is more than 75% of the lobe injury.
You have said grade 5 grades, right? What is grade 6?
Yes. That is avulsion, hepatic avulsion, that is.
Good. It's I think you did a great job telling this because it's difficult to remember. I couldn't even remember, and Alhamdulillah, this station did not come in my exam. Okay. So could you please tell me how will you manage this liver tear?
I'll start off with ATLS protocol, airway breathing and circulation part, and I'll go for biochemical investigations as well as fast scan. If I come to know that there is free fluid in abdomen, then a patient should be managed. Foley's catheter should be passed. Fluid, as you mentioned earlier, 1:1:1 should be given. And if patient is declining as far as the clinical status is, we should go for surgical management. That is opening the abdomen, and we will assess the injury. If patient is hemodynamically unstable, otherwise we will go for CT scanning and assess the injury
Are
radiologically.
you telling me on the basis of grade, or are you telling it on generally? Because I think, as far as I remember, it was on the basis of grade.
I'm telling on the clinical assessment and the patient presentation.
Yeah.
If he presents to us,
Yes, I understand that because we follow a lot of protocols wherever we practice, but you have to mention it according to grade. So for grade 1 and 2, it can be managed conservatively with no surgery. The patient might require blood transfusion, and you need to do follow-up ultrasound to see whether the collection is increased or not. For grade 3, you have two options. If the patient is stable, you can go for conservative. If the patient is unstable, you have to go for surgery. For grade 4 and 5, if there is vascular injury, I think it is an indication of immediate laparotomy. For grade 6, the patient will be hemodynamically unstable, and you need to do immediate laparotomy. Okay. Okay. So
yes.
consider this patient is in shock. So why CT is not a good option of investigation for this patient?
As patient is hemodynamically unstable and patient is in a severe shock, we will not be wasting time. I should not use the term wasting, though. We'll go for the surgical management straight away. We will open the abdomen. We will assess the injury. Either we will
You have to
pack
do
the
something before that.
uh,
You have to do something before that. Tell me the name. I think you are, for the first point you were right. You have to do
laparotomy.
something. Huh?
Is that laparotomy you are
No,
asking?
no. Something before laparotomy. What you will do?
Fast
You are not
scan
doing.
and
Yeah.
again ABC protocol, IV fluids and blood
It,
transfusion to be done
oh,
as
you
far
don't have
as
to tell
the
those.
clinical status is.
You don't have to tell those. Sorry, I'm interrupting, because in my exam I faced this. Like, he's over interrupting. We don't have to tell this. You don't have to tell this. It was in a critical care station. So sometimes when the examiner, is not accepting any answer, he will be doing that, stopping, then tell, stopping, and then tell. So just tell that you will be not doing the first point was right, but you will do fast scan. That is focused abdominal sonograph. I forgot the full form. I'm extremely sorry, because it will not cause any delay or urgent damage control surgery. Okay. But if you tell about fast, please tell the full form. If
Okay.
you tell full form, it will be, the examiner will have a good impression on you,
Okay.
because whatever the things you are saying, he will be checking the checklist. But if he has a good impression on you, you can get the 4
Okay.
marks of professionalism, that is out of 20 in the crisp stations. And you have 3 crisp, sorry, 3 crisp stations. Yes. So first, consider that you have done a fast scan. Okay. So what are the areas that you will look for?
In fast scan, we look for the 4 areas mainly. That is quadrants, the right upper quadrant and the left upper quadrant. Then we'll go for the pelvic view, and then we look for the pericardial, the subxiphoid view.
No, you have to tell that you will typically look for fluid in 4 specific areas. Okay. Pericardium, perihepatic space in the right upper quadrant, perisplenic space in the left upper quadrant, and pelvis. Tell it like this, okay?
Okay. Okay.
So I don't have any other question in this station. You guys are doing great. And Dr. Esther, all the very best. I think you have very few days left for your exam. And in spite of this, you are attending the mock, which is very courageous because uh, that's a tough thing to do, because focusing on sometimes for this part, because I remember before my exam I was a bit perplexed what to do or something, and doctors I you might think that I'm a bit overstepping, but I gave the exam. I had experience, and I have seen how these things happen. So I was trying to give the exam uh, experience on the basis of online, which is tough to give, but that's all I could do, because sometimes examiners interrupt. It's a very common thing. Sometimes examiner don't say because in critical care station, I think I got a new question in the fluid overload station, and he was like, I was starting to, then he was like, stop it, then tell it properly. So these things will happen. Okay, don't get disheartened, because and because new questions come every now and then. It's a very common thing, new questions coming, but try to focus on the things that you have read, because 90% or more comes from these common questions, and try to read whatever authentic source you can get. As I have mentioned, the authentic source is only the OG Sala, because I gave exam reading his things and I passed. Because in my as I have
And
said
that
the past. Yes.
I do have a question, if you don't mind.
Yes.
When we were discussing about after the grades of injury or the liver injury divisions, you asked me for the management, how you will manage the patient with shock if he comes with this. And then I had to tell with liver injury grades, like in grade 1 and 2, I'll manage this way. Like how come we know that the what level of what grade of injury he has? We did not go for any tests. I did not mention even a CT scan. And
No, no. Whenever you are mentioned for liver tear, you will be doing a CT scan. Okay. Past you are doing for fluid. Past is a thing that you are doing for fluid, but for liver tear, you have to do a CT scan. Okay. So firstly, you will
even
be
if the patient is, even if the patient is hemodynamically unstable and we see free fluid in
no,
abdomen on a fast.
no. If you see free fluid on the abdomen, you won't be needing, you'll be doing a damage control surgery for that. But if
Yeah.
if the patient is a bit stable and you are not seeing any free fluid, you will be able to see. Then you will think, because you will not be able to see liver tears in fast, as far as I know, as far as I have seen.
Yeah.
So, so in that case, you need to do a CT when if you are not able to find anything in the fast. Okay. So sometimes things like this happen, but
Okay.
these won't be asked in your exam. And I think I'm because you might think these are logical things, but whenever you are reading for the exam, sometimes you have to just see the things that are written as that, because I think a lot of us think a lot of things, because we are more or less everyone is doing a job in any or in everyone is on training. Things differ, but we have to pass the exam no matter what. And as I have said, that the pass rate is going down day by day. Earlier in Kuala Lumpur station, it was like more than 50%. Now it has come down to 30%. So I think people, you guys have to be bit careful how you speak or do in the exam. Try to practice as much as you can. Some people may not have partner with them, which is very normal. I did not have any partner with them. I used to practice my exam by giving mocks, and for examination and procedure, I had maquettes for procedure. I used to do like that. I practiced catheter, by how do I speak? Like putting a hole in a plastic bottle and inserting a stick and then practice.
Mhm.
Okay.
Mhm.
So all you
So may you guide me on it if we discuss about this particular scenario, like you are giving me the lead, like you tell me the grades, you ask me for the grades of injury, and I tell you, and then you ask for the management. And then in management part, I should start off with again ABC, or I'll be saying that in grade 1, 2, I'll manage patient
Firstly,
this
you will
way.
tell that you will manage according to ATLS protocol, since this is a trauma patient. Then you will say that you will need a multidisciplinary approach, and then tell about the management according to grades.
Okay. Okay.
Okay, so that concludes my advice. I think I might have given a bit more advice, but seeing people, I think people need advice a lot nowadays, given that the scenarios are changing regarding the exam environments are changing. It might seem a bit excess to you. People used to give me a lot, and I used to like, I used to curse, like swear words that what you do, I don't need these things and blah blah. But when you give the exam, you understand that these things are needed. And I'm very grateful that I had seniors who used to give me a lot of advice, and I hope I can be that type of uh, I don't know if I'm senior to you or junior to you. I hope I can be someone whose advice works for you. So that would be I think that would be my uh, success, that you guys are heeding my advice and doing great. I think that would be of a great achievement for me if you guys pass and if you guys do great. Okay, so thank you everyone. And I think I speak a bit loudly, and I think I speak a bit quickly. I hope I'll be able to correct that soon.
Thank you very much, Doctor.
All the very best, Isra.
Yeah.
Okay, and I hope you do great, because these days are tough. I have faced those. Please be calm whenever in the exam. Please don't be, and as I think you are a Muslim person, and please, whenever you go for the exam, try to read to I think your exam is in morning or evening, I don't know. My exam was in the evening shift, and I could not read the Zohar Namaz, and I felt upset for that. But if you have exam, you please try to read 2 rakat nafal namaz after Fajr. I read that, and I think that changed my life a lot. Okay, all the very best. And if you guys have any query, please you can contact me or with Dr. Zahid if any problems arise. And please try to practice a lot. Even if you are free, sometimes you might feel that yes, it's getting bored. Try to practice your examination on the pillows. Pillows are the best friend in this case. I used to do with the pillow. I think I did most of my examinations in the pillow. And yes, the Dr. Shahriar has given a very good thing. Consider the actor as a real patient. Yes, they are very good at acting. And I think I need to give one advice to Dr. Isra. Since you are having exam, so sometimes please ask the name. And if you forget the name of the patient, try to ask in between the examination.
In between examination,
Yes, I remember in my abdominal examination, I was asking the name. I asked the name and I forgot. Then I was doing the percussion. I started the percussion. I was like, "Can you please tell? I think your name was this." Or I was like, "Can you please tell me your name?" And just forgot. Because sometimes the examiners were very shrewd and we were very cunning. They asked the name of the actor, and if you don't know the name of the actor, that they might cut a good amount of mark from the professionalism. Okay.
We are it's accepted to take any paper for notes or like this.
No. You will be given everything. You will be even given a pen during phone call. Okay.
In all station they will give paper to take some notes.
No. You don't. Okay. You are telling about the phone call and history. Yes, you'll be given paper. You will be given a paper.
No, I'm asking if I want to just take some notes about the history in a paper, not to forget these notes.
You will be given paper in history session. Of course, you'll be given paper. Not in the examination.
Not in exam.
Yes, you'll be given paper just in history, and the counseling stations and the phone call stations. Otherwise, no. And better to take a stethoscope with you, because sometimes I remember sometimes the stethos are given very low quality. So if you have to do any respiratory or cardiovascular examination, you might be in a jeopardy.
Sorry, cardiovascular. What?
Yes, I think better take your stetho with you. I took my stetho with me.
Anything else other than stethoscope?
No, just nothing. Don't take anything. No pain, nothing needed.
Can you add, please?
White coat important. White coat. White coat.
No white coats needed. None of us wore white coats. And you have to, keep your hand free up to the elbow. You have to keep your hand free up to the elbow.
Can you add,
Hello?
can you add something to it, please?
Sorry, I have
I'm not.
to hand what?
Yeah, can you add something to it, please? I said, can I
I'm
add something to it, please?
for what?
I want to add on something to it on this particular part she's asking, because I just attended a conference held by the Edinburgh team, and they typically mention that you do not carry any sort of prop with you. Go with a bare hand. Everything will be provided. You will either not be loud. You need not to take anything with you, not even a
But
pen, not even a
I understand that. But
stethoscope, not even.
yes, yes. I'm understanding what you were saying, but in our exam, some of the exams that we have given, we are asked to bring stethoscopes, because it was written that the stethoscope might not be good, so you might fall in problem if you examine with those stethoscopes, because some of the stethoscopes are low quality, so you might not be able to hear the sounds exactly that you want to hearing. Because in case of cardiovascular examination or respiratory examination, you have to your main target focus is on the hearing part, that is the auscultation part. So you can take, if they say that don't take, just keep it on your bag. You will be given a room to keep your bag, so don't worry, you can take stethoscope. I remember taking.
Doctor, you mentioned
I took it for the operation.
you mentioned
Yes,
anything
Dr.
yeah about dress that our
Yes. Okay, as far as I remember, I was told that try to wear a beige or black color pant. That would be formal type dress, and please keep your hands free up to the elbow. Okay.
but I think it will not in my dress it will be hard to keep it till elbow.
But you
Is it
need
a
to
must?
keep it up to elbow. I understand that you might have hijab, or you have religious, but that's the thing, that you need to keep up to your elbow. Otherwise, I think there are some I don't. As far as I know, that you need to keep it up to your elbow. You can fold it and keep it up to your elbow, but in all the stations, you need to keep it up to your elbow.
I have to fold it. Okay.
You can keep it fold. Don't worry, but just keep your sleeves up to your elbow, because you will be doing examination and these things. And for the examination, I'm all giving this advice because I know how Dr. Esther is feeling right now. Please, if you even don't have any like sanitizer in the room, just try that you are just give a demo that you are washing your hand. Okay, that also has mark. Every single point has a mark, and by mistake I was seeing the checklist of one of the examiners. I could see, because the rooms were small in my station, in my exam, so I could see the checklist, and every single step has marked. And you can't imagine that the steps sometimes what are the things that has marked. Even if you are saying sorry, that has marked. If you're saying that the patient is having pain, you are asking for painkiller, that also has marked. Please try to be as much as gentle, and please try to explain that I'll be doing this. You might feel pain. Please tell me if you feel pain. If the patient says pain, painkiller is very important. Just say, if the patient, oh, I'm sorry, do you need any painkiller? Can I proceed? Just memorize this thing. Whenever you are doing any examination with the pillow or someone, Please memorize. Oh, I'm so sorry you are feeling pain. You want a painkiller. I'm sorry you're feeling pain. Painkiller. Okay. That's this part also has a huge amount of point.
Mhm.
Yes, but doctor, can you please repeat if there is no hand wash, then what to do? Hand
I'm just
sanitizer.
do type of demo, like you are just pretending that you are doing hand wash.
Okay, okay, got it.
Okay, and in in the abscess and the procedure stations, I remember one of in the own suturing station, I was not given in gloves, and people have volunteers. You guys will have a lot of volunteers outside. Whenever you have any doubts, please ask them. Like in my phone call station, I was not understanding how you have to press the phone while to call the consultant. I was like, please come and help me. So if you have any problem, please ask the volunteers. There will be a lot of volunteers. You can't imagine how much volunteers there are there.
Okay, so do you need to do a real call to anyone?
Yes.
Okay.
And about the procedure one, try whatever you do, try to discard these things. I need to discard, because you have to discard a lot of things in this station. So practice doing these things. And every day, whenever you are reading, try to practice at least one or two procedural examinations, because people forget a lot of things, but these are the approaches. There's a small things that will help you gaining pass. Because when I gave the exam, I was like crying for 1 month straight, because I think I gave a very bad exam. But when I discussed with some of my seniors were like, you did whatever you had to do, and you could complete. I discussed what I did with them, but when I saw my marks, I was like, I got more than I deserved, I think. So I think these are the very small things that I did which made me pass the exam. That asking for painkiller, do you need any painkiller? I am so sorry. Telling I am sorry very often. Explaining the procedures, explaining what to see, explaining everything, doing this, and trying to finish within time. After that, I would like to do this. Okay, so these are the things that carry marks, and every single mark is important. So these are the things that will make you pass.
Yeah, so doctor,
Hello. I'm sorry, Dr. Zaid. I think people are getting bored, but I think I'm only doing this for Dr. Isra because she has been so regular, and I think she deserves a lot of this type of advices from me. I'm so sorry, Dr. Isra. I'm taking so much of your time.
No, it's very helpful. It's very helpful, your advice.
You have been from the start of my session, so I think this is the least that I can do for you. And I think you might have a lot of books. Okay, so one thing for sure, you guys have Sala books. I know everyone has Sala books. Please, whenever the